Welcome to our webinar, Shared Decision Making. This webinar is part of our Living with PNH series. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to thank Novartis for their generosity in providing sponsorship for the Living with PNH program. Before we get started with the webinar, I'd like to let you know about an opportunity that you can meet and share experiences and talk with others who have been diagnosed with bone marrow failure diseases. We do host each month virtual support groups. All of the support groups are led by patients and caregivers just like you, providing an opportunity for you to talk about your illness, share experiences, and be able to learn from each other. All of our support groups are listed on our website. Once you register for the support group of your choice, you will receive an email confirmation, and part of that email confirmation provides the information on how to join that group to be able to participate. So if you have any additional questions, you can find the support groups on our website, which is aamds.org, or give us a call at 800-747-2820, and we're happy to help you with finding a group that would meet your needs. So this program is going to be an interactive program between myself and Dr. LeBlanc. So if you have some questions, please do submit them while we're chatting about shared decision making. To submit your question or comment, you're just going to look to the right-hand side of your screen, and you're going to see a Q&A icon on the right. Just go ahead and click that. It'll pop up a screen, type in your question or your comment, hit enter, and we'll be filtering through those questions throughout the program. So when asking your questions, I would like for you to do two things. Submit your question all at the same time, and please do not share any private health information in your question. Our speaker today cannot answer any specific questions related to your personal health care. I have the pleasure today with chatting with Dr. Thomas LeBlanc, who is a medical oncologist, a palliative care physician, and a patient experience researcher. He serves as the Chief Patient Experience and Safety Officer for the Duke Cancer Institute. His clinical practice focuses on caring for patients with hematological malignancies. As the founding director of the Duke Patient Experience Research Program, his research investigates common issues faced by patients with cancer, including issues of symptom burden, quality of life, psychosocial disorders, prognostic understanding, and the treatment of decision making. His work aims to improve patients' experiences living with serious illnesses. It's my pleasure to welcome Dr. LeBlanc today.
Thanks so much for the invitation and for the kind introduction. Happy to be here.
Well, we're so glad you were able to join us. Dr. LeBlanc, what is shared decision making?
Well, it's a really great question because this is an idea that many people haven't heard about before, or maybe they've heard of it, but they don't know exactly what it means. I'll maybe spend a minute or two going through some background about it because I think that will help to make it clear what it is and what it isn't, and maybe why it's something that many people still don't know about or practice. So it's a relatively recent idea. The concept of shared decision-making probably was introduced formally sometime in the late 1990s. So it's not all that old. And the idea of it is that it's a model of decision-making where it's not one directional. So if you go back to the old sort of the Marcus Welby days of medicine, if people know that reference, the old television show. The idea was you come to the doctor and they just tell you what to do and you just do it. And that doesn't really jive with how most people want to make decisions today. You know, things have changed about perceptions of autonomy. Patients are much more well informed about what's going on, but most importantly, there is not always a clear right answer for what you do in situation A or B or C. Rather, there might be 2 or 3 reasonable options, and reasonable people might disagree depending on who they are and what's important to them. So the idea of shared decision making is that the patient and the clinician participate, and that there is not a right answer, but rather it is a preference sensitive decision, meaning that depending on the patient's values, goals, preferences, what they're willing to go through, where they're trying to get to, that matters just as much as what the physician or other clinician knows and understands about the physiology of the problem that the patient has and what treatments might be available. So there's kind of a joint sharing of information where a decision is somehow made jointly together, although that can vary exactly what that looks like. We'll talk more about that later, and that you come to a decision together about what to do next. And this is a concept that, as it's become a bit more mainstream, the what used to be called the Institute of Medicine, now the National Academies of Medicine, jumped on board with this idea and endorsed it sometime around 2001, I think it was, and said shared decision making is really part of what we would refer to as a kind of patient-centered care. It's more person-centered and patient-centered. We're not just telling people what to do. So if you think about it in another context, many people are more familiar with what happens when you undergo a procedure where you have to provide what we call informed consent. So shared decision making takes it a step beyond the informed consent model. And what I mean by that is informed consent is really just a process whereby the clinician tells you the risks and benefits of a procedure, like a surgery, a bone marrow biopsy, something like that, and you say, okay, I understand. Now I'm going to sign on the dotted line, and you proceed with the procedure. And that's just, here's what we want to do. Here are the risks and benefits. Do you have any questions? Let's proceed. And you could see that that's not really at the same level of bidirectional exchange, assessment of preferences, values, et cetera, that I just described earlier, that really is shared decision making. So shared decision making takes the informed consent model and ratchets that up in a meaningful way to something that more honors informed preferences and makes that part of decision making, rather than the clinician just tells you what they think you should do. So it's kind of this merger of more modern, high quality communication in healthcare from the clinicians with the idea of more person-centered and patient-centered care. So I will end my, I know, kind of long answer now to this question, but this is an important place for us to start with a formal definition for you. If that, if what I've said so far hasn't been clear or explicit enough, I'll give you a definition from one of the preeminent experts in shared decision making, Glenn Elwyn. And he wrote this in one of his papers in the BMJ in 2010. And he said, shared decision making is, quote, an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. And, if I just read that to you, you might have said, I don't really know what that means. So hopefully after I gave the kind of prequel to the definition, it all comes back full circle in a way where you have that sort of aha moment saying, okay, now I get what he's talking about. That's why I didn't want to start with just that definition, because it's a little bit confusing if you just read that out of context. But hopefully that's a good introduction to what we're really even talking about here.
Thanks, Dr. LeBlanc. That was great. And why is shared decision making so important?
Well, the reason why I think shared decision making really matters is that we find that a lot of patients and people don't necessarily get the care that they want or that they say they would want. If they truly understood what they were choosing or truly understood the likely outcomes. So one of the challenges that we face in healthcare is that there's this humongous asymmetry of information. And it doesn't matter if you are the smartest person in the world, when you are the patient, you just don't have the experience that the physician has in treating people with that condition. And so you can read everything there is to read and understand as much as you can possibly understand as a layperson. And there are always still going to be things that aren't there in the things that you've read, things that are unsaid or unstated, unwritten, maybe not yet understood, that clinicians would tell you this thing is important or that thing is important. This is what my other patients tell me. You just can't ever possibly get all of that, no matter how much you consume of healthcare information that's out there. And as it turns out, when you do share decision making in its truest sense, it really does change what people choose for their healthcare. So the most prominent examples about this come from non-hematology and non-oncology settings, but this is where a lot of shared decision making has been grown and developed. A great example would be in hip or knee replacements. So this is an area where it's sort of an elective procedure, right? You know, you could have very bad arthritis and have pain, but stick it out. And you could go see an orthopedic surgeon who tells you, you know, your knee's pretty bad along. I can give you some medicine to help with symptoms. It's not going to fix the problem. I could do this injection. It might help you feel a little bit better for a while, but it doesn't help everybody. But at some point, you're probably going to want to have surgery and get an artificial hip or knee replacement. And that's the thing that really could make you feel better. But that's not the whole story. There are risks of surgery. You could have infections. You could have a blood clot. Your pain could end up not being any better. It could be worse. You could have mobility issues related to a surgery, especially if you're not able to do the physical therapy afterwards, or maybe no matter what you do, you get an infection, you have to have the hardware removed, then you end up kind of worse than you were. And most people won't get any of those bad things, but a small percentage of people statistically will have one of these bad things happen to them. So when you're going into that decision-making process about whether to do a hip or knee replacement, you need to really understand those things, but it also needs to be mapped to what's important to you. How much is this impairing your function? What are you trying to get to? Are you somebody who's a runner who can't run anymore, and that's been a really important thing in your life, and you really want to get back to that? You know, you're very motivated to get that procedure done. Or are you somebody who, you know, maybe is more sedentary and the impact functionally is maybe not as significant as it would be for the person who's the runner. And, you know, maybe you have more to lose if you lost that little bit of function. Maybe you're not going to be able to do the rehabilitation as well and be at risk for having a complication. So this is where every person is different. Every patient is different. The old model of informed consent, where we just tell you the risks and benefits and I have you sign on the bottom line, isn't really meeting people where they are with what's important to them and what their lived experience is. So going back to this example of hip or knee replacement, studies have shown, very high quality studies, that upwards of maybe 1 out of 5 patients who participate in a shared decision-making process will choose a less invasive procedure. So maybe you have a few different surgical procedures. Maybe there's a total knee and a partial knee replacement, for example. And once you learn about the risks and benefits and all these trade-offs through a truly shared decision-making process, when that's done in the correct high-quality way, you're actually less likely to choose the aggressive surgery. And it's not that this process kind of talks you out of doing something that you need or that you should do, but rather helps you better understand all that's involved, not just the benefits, like, oh, I got to do this surgery so I don't hurt anymore, but also what the risks and trade-offs might be. where we don't always describe those things in ways that are helpful to patients and families and that are accessible. So if you look at studies of shared decision aids where somebody has gone through a formal process of developing this thing, it's a guide, what we call a decision aid. It might be a handout, it might be a website, it might be some videos you watch before a visit, maybe something that prints out after you answer some questions. They can look in lots of different ways, but studies of shared decision aids for hip and knee replacements have been shown to reduce surgeries by almost 40%. And that has some downstream implications for people getting the right kind of care for them. And that's great for the patient. It also actually has some benefits for the system because that reduces cost of care. So if a whole bunch of people are getting surgeries that maybe they wouldn't really want and then have complications later that cost a whole lot for the healthcare system, and then they come back and say, I wish I hadn't done that thing, that's bad for the patient. It's also bad for the system. It creates waste. That's not good for anybody. Other people who need procedures can't get into the operating room. So it's been pretty clear that shared decision-making is better care for that person, but also probably better for our whole healthcare system if we have people being better informed and better matching their treatments to who they are as individuals, to their values, goals, and preferences. So hopefully that helps to really underscore why shared decision-making is important and at least get to some of the benefits of it.
Right. Thank you so much for sharing all of those benefits. It sounds like shared decision-making is very important for patients and getting the health care that they want for themselves. Are there some disadvantages of shared decision-making?
Well, there definitely are. I do actually want to get into one other benefit or reason to do it before we go there, though. Is that okay?
Perfect. Absolutely.
Okay. So the other side of this story is that shared decision making is very clearly something that on average people really want if you ask them about it. So, if you show videos to patients or families about decisional styles, and they see one that looks more like shared decision making, and they see one that looks more paternalistic, like the doctor's telling you, here's what you should do, and not asking you about your experience and what's important to you, increasingly with time, people prefer the shared decision-making model. So there have been these big, huge studies, systematic reviews, meta-analyses where investigators have looked at everything that's published. And what we're seeing is that prior to about the year 2000, maybe half or so of people were interested in shared decision-making. Since then, it's more like 70, 75+%. So the more modern aged people are more interested in this kind of decision making. And it makes sense. It's just more consistent with kind of how we tend to do things in general. We're all more informed consumers on average. There's more information everywhere on the internet. You don't just go out and buy a phone. At least most people don't. They read about it. They think about what they want. They think about whether it's worth spending, $1,000+ on a really fancy new phone, or if something mid-range that they could get for free with their phone plan or for a lot less money maybe would meet their needs as well. What's important? What do you really need to have? What do you not? Maybe it's the size of the screen. You want the one that folds. It's kind of the same thing with some of healthcare decision making now, especially when it is preference sensitive. So an example where this has played out in cancer care has been with prostate cancer treatment. So men with prostate cancer, if it's an early stage, kind of lower grade prostate cancer, may have at least 3 or more different decisions. It could be radiation therapy alone. It could be surgery alone, or it could be what's called active surveillance. Sometimes people have called that watchful waiting, but really active surveillance is a more friendly term that's more consistent with what it is. We're paying attention. We're not sort of waiting for something bad. We're paying attention. And studies suggest that for the right kinds of patients, there's no difference in outcomes. People don't live longer or shorter if they have surgery or radiation or no treatment when it's an early stage prostate cancer. There's humongous trade-offs around side effects that patients will have from these different kinds of treatments or from observation. If you just get observation, You might be just nervous and really worried that you have cancer and we're not doing anything about it, even though that's not worse from an outcome standpoint. You're not going to live shorter periods of time because of observation, at least from what all the studies show us. You might not emotionally be able to handle that. Like, I have this cancer and you're not going to do anything. I can't live like that. On the other hand, other people might not be good candidates for surgery, and they might be faced with just radiation versus active surveillance. And they might say, I really want to do something, but then the side effects of the radiation can be significant around continence, for example, sexual function, etc. So these are all really important things to people. And yet each individual person may care more or less about some of those different things than the other. That is a truly preference sensitive decision. And this is increasingly what people want out of their healthcare. Even if it's cancer care, there isn't always a clear right answer. And the other side of the coin here around why we really need to talk about this more and think about it more and teach physicians and other clinicians about it, how to do it, and educate patients and families to ask for this, is that studies show us that unfortunately patients tend to be pushed into a decisional style that is not consistent with what they want. So there is this interesting decision scale called the Control Preferences Survey that has some questions about how you want to make decisions. And when patients have been given this survey and then surveyed about how they actually made a decision, it turns out that somewhere in the range of, say, 40-45%, so almost half of patients were forced into a more active role than they wanted, where maybe the clinician was saying, here's the options. What do you want to do? And that person is thinking, well, I don't know. I want you to tell me what to do. Maybe a person wants a bit more of that paternalism in their particular patient-doctor relationship for that decision. So some people are pushed to decide more actively without enough support. Like, here's your 3 options. Here's the trade-offs. Tell me what you want to do. And they'll ask the doctor, well, what do you think I should do? And the doctor will say, I can't tell you that. I'm not you. That's not fair. That is not shared decision-making. That's not modern medicine, modern healthcare. But most of us have not been taught how to elicit patients' values, goals, and preferences. And so we do the informed consent model. Here's your options. Here's the risks. Here's the benefits. Tell me what you want. It's like going to Jiffy Lube for the oil change. You want the synthetic oil, or you want the regular dinosaur oil. There are different costs. I can't tell you what to do. Or here's what I'd recommend if you really want your engine to last 200,000 miles. Go with the synthetic. It's a little more money, but better engine protection. But it's up to you. You tell me what you want. Healthcare is not getting an oil change, and sometimes we do sway a little bit too far to that end of the pendulum with the more sort of autonomy driven healthcare. It's not that you just come to somebody and say, this is the medicine that I want. It doesn't work that way because of the asymmetry of information. But there often is this pushing of people to make decisions that they're not prepared to make, that don't fit with their decisional preference and style. So the mistake to make is to think that shared decision-making means get all the info and then tell the doctor what you want to do. Then it's not shared either. Then it's just the patient making the decision. Shared decision-making is in the middle. It's not the doctor tells you what to do. It's not the patient tells you what to do for them and what they want. It's the in the middle. It's the bidirectional, the sharing. So I told you that a lot of people are pushed into a more active role than they want. Unfortunately, even more people are pushed into a more passive role than they want, at least from these data. And they're a little bit old now. Hopefully this is changing. But the study that I'm thinking about from 2010 in AJMC showed that 43% of patients were pushed into a more active role than they wanted, and 57% of patients were pushed into a more passive role than they wanted. So many people wanting to play a more active role in their healthcare decision-making and not being given that opportunity. And unfortunately, what ends up happening is that clinicians develop these sort of expert spiels, these information-laden speeches that they deliver repeatedly to patients that they see with the same situations clinically, and they don't adapt that to the needs of that patient and their family and situation. So they don't ask, how do you prefer to make decisions? What kind of information do you want? Who needs to be there at this meeting? Instead, they just do the same spiel every time and they don't meet the patient where they are. So that's the piece that we have to get beyond, but it's going to require teaching clinicians more about how to do shared decision making. And this is not something that was part of any curriculum that I did in medical school. And, I'm not that old at this point. I haven't been doing this for that long. I joined the faculty at Duke in 2013. So I was in medical school in the early 2000s, graduated in 2002. 2006. And this isn't something that we were being taught at that point. So there's a whole lot that needs to be done, but that's really the background information that you need to know about shared decision making. So I know I've talked a lot, but I hope that that's really useful information for the listeners.
Absolutely. Thank you so much. And are there some disadvantages that you'd like to discuss as well?
Yeah, so there are certainly some disadvantages to this process. One of them, I would say, relates to what I was just talking about, which is the being pushed into something that's not congruent with how you as a patient and person want to make decisions. So, if you do it correctly, shared decision making shouldn't result in you being pushed to make decisions in a way that you don't want to. But there's a lot of kind of half doing shared decision making that results in people feeling like they were pushed to play too active of a role, especially. So that idea of I just tell you what the options are and then you tell me what to do, that's not really shared decision making, but that's what ends up happening when people think that they're doing shared decision making in their clinic. I think that's one of the big downsides of trying to do this. So if you do it well, that won't happen. But I see and hear a lot of this, here's all the options, tell me what to do. And then when patients ask, well, what do you think I should do? Or what would you do if it was your mom or dad? Or what would you do if you were me, doc? And they'll say, well, I can't tell you what to do. That's unfortunately the downside of what happens when people are trying to do shared decision making, but not really knowing how to do the preference and values elicitation piece. Because the correct answer to that important question from a patient and family should be, well, I need to know better who you are and what's important to you to be able to answer that question. So let me ask you some other questions about your goals, your preferences, and your values, and then I'll do my best to give you a recommendation that is most likely to help you get to that point where you want to be in the context of who you are, what's important to you, and what you're willing to go through to get there. That's what it has to be. So that's the piece that we're missing. So that's the one big potential downside of trying to do this if you're not really equipped to do this as the clinician. The other downside, I think, is that this can take more time. You could imagine having these kinds of discussions is not necessarily easy. There's a whole extra step here around better understanding that patient and what's important to them. It's not just me telling you, here's your 3 treatment options and here's the pluses and minuses of them. And, that's my spiel. And what do you want me to do? Which is kind of what we often do. It's taking that extra step of saying, tell me more about you. What's important to you? Tell me about your family. Tell me what kind of support that you have. What have you read so far about this diagnosis? What are you worried about? What might be a situation that you wouldn't be able to handle, a situation that would not be acceptable for you. Sometimes people will do what's called best case, worst case decision making and conversation to say, here are the 2 extremes. Here's the best possible. Here's the worst possible. Here's where I think it's most likely to go for you. What do you think about that? It can help this idea of preference scaling or outcome scaling to help people better understand the range of possibilities for any one decision, how it could go, and what's most likely. That can be really useful in informing a decision-making discussion and making the decision. And the other piece that maybe is, I don't know if this is really a downside, it's a limitation, I guess, and this maybe gets into one of our next questions. There are not good decision tools out there for most of the even common hematology oncology scenarios. So most of the things that I'm facing in clinic when I'm treating patients, there isn't a decision aid that I can just go to and say, hey, let's look at this website together and let's pull up this thing. Let's print out this decision aid and you fill this out and come to the clinic and we'll do it together. There aren't those kinds of resources for most of the scenarios that I would want them in. There are ones for more common issues in healthcare. There are ones about whether to take a blood thinner if you have a heart rhythm issue, a common one called atrial fibrillation. There are ones about whether to take a cholesterol lowering medication and look at how much you would reduce your risk of having a heart attack or a stroke by taking that medicine, and then how many people like you would have a side effect like muscle pains and aches or increase in their liver function tests. And you can see how many people out of 100 would have the good outcome or the bad outcome and tailor that to you with your personal cardiovascular risk profile. Plug it into the calculator. So the Mayo Clinic has a whole bunch of these. There is a place in Canada, McMaster University, that's really pioneered some of these decision tools and created a bunch of high quality decision aids. But in cancer, there are not that many of them. And I and others have been working to develop some of these tools. The problem is the treatments change so quickly, it can be really difficult, if not impossible, to develop a tool that's still actually accurate by the time it gets validated and deployed. Sometimes new treatments come online, we change what we're doing, and it can be really difficult to get ahead of it. So it's one of the major limitations that we have out there.
Thanks, Dr. LeBlanc. We have a question from the audience, and the question is, if I'm seeing a hematologist for a second opinion, how would I go about asking them if they practice shared decision making? Is there a certain way I should ask this question?
Yeah, this is a really, really important and very good question. It's very difficult to answer, honestly. I'm not sure that there is a clear right answer or best answer. I've yet to see really good guidance about this, unfortunately, and from the standpoint of hematology and oncology. What I personally would recommend, and hopefully this at least helps somewhat, is that you be very transparent and upfront about this preference when you first sit down with somebody and say, before we get into the visit, I want to make sure that you understand something important about me, that I'm somebody who really values a shared decision-making kind of process. And I know that isn't something that all clinicians are comfortable with or have been taught how to do, but it's really important to me that you get an understanding for my values and my preferences, and that I have the opportunity to participate in decision making about my treatment. If there are multiple options and reasonable options that different people would choose, it's really important for me to go through that process with you of you understanding me and who I am and where I come from and how that might impact what treatment we choose together. Now, that would be the way to do it in the truly shared model. On the other hand, it's really important to also express a preference if you don't really want to be the one actively making the decision in that way. So I've had many patients over the years, especially older patients in the Southeast where I practice, who come from a time where doctors were more paternalistic and would tell you what to do, and that they want the reassurance of a doctor saying, I think this is the right thing. And it doesn't mean that every patient gets the same thing and that there's one right answer for every person, because there usually isn't something like that. But you have to express that preference and be able to say, doc, I don't know, you're the doctor. I don't know what the right thing to do is. I can tell you a little bit about what's important to me, but ultimately I'm looking for you to tell me what you think is the right choice for me in this situation. So, if you're just going to ask me, here's your three options, what do you want to do? I'm going to come back to you and say, well, what do you think I should do? What else do you need to know about me to be able to answer that question for me? I need you to tell me what you think is right for me in this situation. I'm not going to be able to tell you. I'm not the doctor. And there are different kinds of patients who feel differently about those kinds of things. Figuring out who you are, where you are on that spectrum is going to be really helpful. You could even look up the control preferences scale. It's called CPS, control preferences scale, and maybe fill out that questionnaire online. And it kind of puts you into three major categories of whether you want it to be very active, very passive, or more kind of shared in the middle. And some people mistakenly think that the more passive decision-making is not shared decision-making. I still would consider that shared, because you've said, here's my preference for how I want to participate in the decision-making. And we're going to honor that and have some informational exchange, but it's going to be more on the limited side. And you're not just going to say, what do you think I should do? There will be a little bit more discussion, maybe making a recommendation. Maybe I'll play a little bit more of a passive role compared to someone who really, really wants to play a more active role. But there still has to be some sharing and involvement of the clinician, and maybe even making a recommendation or pressure testing a recommendation. So I hope that helps somewhat. It's not, I know, a really direct, easy answer, unfortunately. And it does maybe feel a bit uncomfortable for some people to play a bit more of an assertive role in the exam room, to say, hey, this is important to me. I need you to understand this, that, by the end of this visit, this is something that I'm going to want to feel like I'm getting out of this encounter. And, if that's not something you can provide, who should I talk to get that from then instead?
Thank you very much for that. Another question from the audience is it just the patient and the healthcare provider that participate in shared decision-making, or should family members also be involved?
That's a really great question, too. I think that family members and caregivers should be involved as well, but it has to be in a way that the patient endorses and is comfortable with, of course. So, if you're the patient, who do you want and need to be there with you to help you make this decision? I always encourage people to bring somebody else to the visit to help take notes, to help remember things. Recording is something that makes many clinicians uncomfortable, and they are not always going to be as forthright with you in a visit. So I shy away from telling people to record. I think it's better to have somebody there with you who can take notes and ask questions, and then in the car on the way home or later that night or the next week to say, hey, remember that thing that the doctor said? That's what this was about. Or I have this thing in my notes. Did you understand that? Did you remember that? So I think that's a great way to engage a family member, a caregiver, a friend, whoever it might be, to be there with you and to participate in the treatment decision-making. It might be that they help you process later, so that when you go to the next appointment, usually you're not making a decision right there on the spot. You're coming back to the next appointment saying, I thought about it, we talked about it, we did some more reading, we have these couple of questions, but here's what we're leaning towards and why. What do you think? Does that sound reasonable? And then usually that's where the magic happens and the decision gets made. But I think absolutely caregivers or family members or others should be involved. Now, it can't be 8 people in the exam room, probably. It's best to designate one person. You have to be reasonable about the amount of time and energy that takes to do that in the confines of a really busy clinic day for those folks working in the clinic. But having a person there with you is very appropriate, and nobody's going to tell you they can't participate and they can't be there in the room with you. We will always encourage that, really.
Wonderful. Thank you. And you had mentioned some tools that were available to help patients with starting the process. Were there any additional tools that you'd like to mention?
There aren't any particular ones that I could say, I endorse this one, you should look at this, go to that one. I would just say do a little bit of searching for tools that are available from the Mayo Clinic, tools that are available from the institute that I mentioned up in Canada, McMaster, they have a whole kind of decision science place. And there often are decision tools available from advocacy organizations related to a specific disease, or that might be tied to a particular treatment, that maybe a manufacturer of a particular drug or treatment might create some of these tools, commission the creation of these tools, and then maybe feature those on their websites or on those of advocacy organizations. Unfortunately, most of the time, there won't be one for your specific disease and situation, unfortunately. That's the biggest challenge that we face.
Thank you. And our last question is, what else should patients know about shared decision making?
I'm struggling to think of anything else to add that we haven't talked about already. So what I think I should say is to maybe summarize some of what might be the most important points about shared decision making. The one that I really want to underscore is that decision making is a continuum. It's a pendulum. And it goes from completely paternalistic, doctor tells you what to do, to completely consumer driven autonomy of like, I saw a commercial and give me that medicine. I don't want to talk about it, prescribe that thing. And neither of those is really the right thing for many or any patients at all. And that shared decision making is about all of that space in the middle. So it doesn't mean it has to be completely shared. It means there has to be some assessment of how you want to participate in the decision-making process. So you have to do a little bit of homework beforehand. Think about that, maybe do a little quiz, fill out the control preferences scale, and get a sense for how you as an individual or a family, whatever that might look like, want to participate in the decision-making process. So if at the end of that process, you feel good about it, what will that have looked like for you? Would you be the one ultimately saying, this is the one for me and here's why? After hearing about it and having that exchange of information and telling the clinician about you and what's important to you, them telling you about the options, the risks and benefits, that coming together around that and you saying, this is what I want to do, then be able to articulate that. If on the other hand, you're someone who feels like you really want a recommendation, articulate that up front and say, I'm really hoping that at the end of this discussion or the end of this process, you're going to be able to tell me that, hey, what I know about this disease and about the options, and now what I've learned about you, here's what I think is the right thing for you in your situation. To be able to vocalize that, that's still shared decision making. It might be a little bit closer to the paternalistic side of the pendulum, but still not entirely or fully so. All of that is within the realm of shared decision making, and know that it may take a little bit more work on both parts. So not all clinicians are going to be able to do this well or be comfortable doing this well. And some of them will say, I'm not you, I can't tell you what to do. And if that doesn't sit right with you, then it may mean you have to seek out a different physician or a different clinician to help you. And sometimes that means you go a few different places, you see a few different people, you do a bit of extra homework, unfortunately. Not everybody can do this or feels comfortable doing this, but I think that every patient deserves the opportunity to participate in truly shared decision-making. There may not be a decision aid that you can use or go to, though, and that can make the process a little bit more challenging. So hopefully that's a helpful way to summarize it. And I hope all of this information has been useful.
Well, thank you so much, Dr. LeBlanc, for sharing your time and your expertise with all of us today.
You're quite welcome. Thanks for the invite.
Thank you. This session was recorded and it will be available on the platform hub within the next hour, and it'll also be placed on our website within the next few business days. Whoops, sorry about that. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our webinar. Thank you again, Dr. LeBlanc.
You're quite welcome. Thank you. Take care.
Take care.